Good morning. Thank you for the opportunity to present on new treatments for endometrial and uterine cancer. My name is Dr. Emily Coe, and I'm an associate professor at the University of Pennsylvania Health Systems with the Gynecologic Oncology Department. Without further ado, I'd like to proceed with this talk. Thank you for your attention. Here are my disclosures for research, for institutional and individual research support, as well as editorial boards and committees that I serve. For today's talk, I'd like to provide an overview of endometrial cancer treatment. We'll start off first with discussing epidemiology. What is endometrial cancer and how common is it? We'll quickly review signs and symptoms and evaluation diagnosis. Then we'll talk about surgical treatment of endometrial cancer, staging and subtypes, and really delve into precision medicine treatment for endometrial cancer. These include upfront treatments as well as treatments for recurrence. We'll also talk certainly about clinical trials and the most novel therapeutic developments and opportunities to find even more developments and treatments. So starting with epidemiology, what is endometrial cancer and how common is it? Endometrial cancer develops from the endometrium, which is the tissue lining the inside of the uterine cavity. Endometrial cancer comprises over 90% of all cancers of the uterus. There are other types of uterine cancers, such as sarcomas, which arise from the muscular wall of the uterus. However, for today's talk, we're going to focus on endometrial cancer itself. How common is endometrial cancer? In fact, it is the most common gynecologic cancer in women and the fourth most common cancer overall in women. In 2024, approximately 67,000 new cases of endometrial cancer will be diagnosed in the United States, with the associated 13,000 deaths. And approximately 3% of women will be diagnosed with endometrial cancer in their lifetime. There are over 800,000 survivors of endometrial cancer currently. And overall, endometrial cancer, when diagnosed at an early stage, has a good outcome. As you can see down below, 95% 5-year survival if it's limited to the uterus. But if the cancer has been spread to the pelvic areas or beyond, then their survival rate does go down. Now, endometrial cancer is most commonly diagnosed around the menopausal years. As you can see here in the bar graph, the most common age group for diagnosis is in the 50s to 60s. However, there are a fair proportion of women diagnosed with endometrial cancer in the 40s, as well as even 5% of all cases diagnosed in the age range of 30s to 40s. What is most concerning is that endometrial cancer incidence is continuing to increase, meaning there are more cases of endometrial cancer diagnosed each year in the US. And this is increasing by 1% per year in white women, and more concerningly, 2 to 3% rise per year in other racial and ethnic groups. By 2030, endometrial cancer is estimated to become the third most common cancer in females. And more concerningly, more women are dying of endometrial cancer each year, where death rates are rising by 1.7% per year. And you can see that in the figure to our right here, with the red arrow showing that the slope is going upwards for endometrial cancer deaths. And what we can see further is that endometrial cancer cases are increasing in all non-white patients. This figure is a little bit busy with several curves, but I'd like to bring your attention to the blue triangles, the purple diamonds, and the brown squares. Those represent the non-Hispanic Black, the non-Hispanic Asian, as well as non-Hispanic Americans. And you can see that the slope is going upwards, meaning that there are more cases of endometrial cancers diagnosed in these patient populations with time. And the number is only increasing each year. In comparison with the blue circles, that line is not rising as steeply, and that reflects the white population, where yes, there still is an increase in cancer cases, however, not as great as the other racial populations. And furthermore, we see there are disparities where endometrial cancer is more common in Black women. And you can see in particular the greatest bar here with the non-Hispanic Black towards the bottom of the chart on the left, 29.4 cases per 100,000. And here on the right, you can see that most concerningly, the death rate in the Black population is particularly high compared to the other racial groups in the United States. And furthermore, there are disparities in what stage patients are diagnosed with cancer. In particular, in the Black population, there are a greater proportion of Blacks who are diagnosed with cancer that has already spread to the pelvis or even further in the abdominal cavity or beyond. And you can see that depicted with the graph on the right, where 20% of Black women are diagnosed with regional disease and 17% are diagnosed with distant disease, in comparison to all other populations, which are lower at 16 and 9% relatively. And furthermore, we do see that there are more aggressive subtypes of endometrial cancer being diagnosed in these minority populations. Black women with endometrial cancer are more likely to be diagnosed with more aggressive subtypes of endometrial cancer. And I bring your attention to the red square lines on each of these graphs that are depicting the most aggressive subtypes of endometrial cancer known as serous carcinoma, clear cell carcinoma, and carcinosarcoma. You can see that the red line with the boxes is at the top of each of these graphs that represents the Black population. And again, that line is continuing to rise over time. So what are the signs and symptoms of endometrial cancer? The most common symptom of endometrial cancer is abnormal bleeding, especially if this occurs after menopause, which is defined by having no period for 1 year. When there is abnormal bleeding, the appropriate workup is to undergo some testing. This frequently may start with an ultrasound of the pelvis, as well as a biopsy of the uterus, either called an endometrial biopsy or a DNC known as dilation curettage. Frequently, next steps after official diagnosis of endometrial cancer is surgical treatment, and that primarily includes a hysterectomy. Thereafter, that might include additional therapy such as radiation or chemotherapy, depending on the type of the cancer and the stage of diagnosis. Thereafter, when treatment is completed, patients are followed closely, and this is called surveillance, where patients are monitored with checkups in the office, taking a very good history, and also management of their treatment side effects. So what is abnormal bleeding? Again, it is basically bleeding that is occurring with increased frequency, irregularity, longer than it should be. So we talk about duration, and more volume than it should be. Some of the easy questions to ask may be, do you have more than one period a month? If the answer is yes, then that should be discussed with the health provider. Does your period last more than 1 week? Again, if the answer is yes, should be discussed with your health provider. And are you soaking through tampons and pads, changing them every 1 to 2 hours? Again, if the answer is yes, then this should be discussed. Now, specifically postmenopausal bleeding, as we stated, the average age of menopause in the US is 51 years. And so, did you go through menopause? What you want to ask yourself is, have you stopped periods for 1 year and then started bleeding again? If the answer is yes, you definitely want to discuss this with a health provider. Approximately 2 to up to 30% of postmenopausal bleeding cases are associated with cancer. And so the most important step to take is to discuss it and to undergo appropriate testing and evaluation. So knowledge is empowerment. Very long, heavy, or frequent periods in any postmenopausal bleeding should be evaluated because this is the most common sign of endometrial cancer. And endometrial cancer can be fully treated, particularly if diagnosed at an earlier stage, in most cases. And really, it is important to discuss the signs and symptoms of endometrial cancer with friends and family, because the more knowledge there is, the more awareness and the more ability there is to diagnose this at an earlier point. And seeking care from gynecologists and gynecologic oncologists who specialize in treating and diagnosing this condition is truly recommended. So as we spoke about, evaluation and diagnosis of endometrial cancer usually starts with some type of imaging study. The most easy study to undergo is a pelvic ultrasound, and this is considered the standard first step. It can evaluate the uterus very well as the ovaries and to some degree the cervix. And the endometrial stripe refers to the lining of the uterine cavity. Again, this is where those cells originate from. The pelvic ultrasound can be done via transabdominal or transvaginal approach, and the transvaginal approach will likely give more accurate information about the actual lining of the endometrium. Usually the ultrasound is not painful, and the endometrial stripe typically should be less than 5 millimeters thickness in a menopausal patient. So what we are learning, however, is that there are racial and ethnic disparities in the ability of an ultrasound to detect endometrial cancer, and some of these studies just came out in the past few years. In particular, ultrasound may be less effective in women with large fibroid uterus. Simulated cohort studies showed that the transvaginal ultrasound missed almost 5 times more cases of endometrial cancer among Black women versus white women. And another retrospective diagnostic study from guidelines for transvaginal ultrasound detection of early endometrial cancer found 11% probability that endometrial cancer would not be identified using a 5 millimeter cutoff among Black adults. So if postmenopausal bleeding does occur, tissue sampling is strongly recommended. And these issues with the ability of an ultrasound to detect endometrial cancer possibly contribute to the disparities in detection diagnostic workup in Black women, possibly also contributing to more advanced stage of diagnosis and the outcomes that we talked about earlier. So endometrial cancer diagnosis does require a tissue biopsy. And we just want to point out that frequently women ask about pap smears. Pap smears are not designed to identify endometrial cancer. Pap smears are designed to test for precancer conditions of the cervix and for detecting cervical cancer. And we just want to highlight that this is a completely different cancer, gynecologic cancer, than what we are focusing on today. So the endometrial biopsy specifically is a biopsy that is performed in the office. Typically, there's no anesthesia required. It is done very quickly. It is a blind sample of the endometrial tissue where a small straw-like instrument is inserted into the uterus, and it can be done in just a couple minutes with generally very low risk of infection, bleeding, pain, or injury. Another type of biopsy can be done in the operating room, and this usually involves something called a hysteroscopy, dilation, and curettage. With a hysteroscopy, it allows the provider to insert a small camera into the inside of the uterus to look directly at the tissue lining. And then with the dilation curettage, it allows the provider to obtain a sample from inside the uterus. Now, this procedure is done in the operating room, usually under some type of anesthesia, what we call sedation. And it is a very effective means of diagnosing endometrial cancer. Now, when the pathology results are provided, there can be several common diagnoses that you may see. A couple just to review here briefly. There is something called endometrial hyperplasia, and that can be divided into categories of endometrial hyperplasia without atypia or endometrial hyperplasia with atypia. In general, endometrial hyperplasia is more of a precancerous condition of the endometrium, though there can be cases where there are microscopic areas of cancer also found within the uterus when you see this diagnosis. Now, endometrial hyperplasia generally can be treated either with hormones or also can be treated with surgery for those who are definitively done with childbearing. Now, focusing on endometrial cancer itself, as we said, this is a cancer condition that originates from the endometrium. And here we're going to dive into the treatment for endometrial cancer. So once a patient is diagnosed with endometrial cancer, the treatment strategy, as stated, is usually surgery first. And what would make a patient a candidate for surgery? Generally speaking, the goal is to have definitive treatment, meaning the uterus would be removed with a hysterectomy. We would have to consider, is the patient a surgical candidate? Would it be safe for them to undergo surgery, is what that refers to. We have to think about, are there other medical conditions affecting the patient, such as comorbidities, which would increase the surgical risk for the patient. We also have to consider whether the patient has any concern for tumor already spread beyond the uterus, in which case surgery first would not be the best option. So we would undergo preoperative testing, such as imaging studies. There are other patients who may want to preserve their uterus, for example, younger patients with a diagnosis of endometrial cancer. And in this case, we consider more hormonal medical therapy rather than a hysterectomy. And with these conditions or these cases, we have to think about, would the patient be able to tolerate these type of medications for several months to a year? Would they be able to undergo repeat biopsies? And what could be the success or failure rate of actually resolving the endometrial cancer in these patients? This is a very refined discussion with the patient and their provider in these conditions. So the sequence of treatment, as stated, typically would be surgery with or without follow-up radiation chemotherapy, otherwise known as adjuvant therapy, then followed by surveillance, which also refers to close monitoring. Now, if a patient is found to have cancer already outside of the uterus that's spread to the abdominal cavity or other areas such as the chest, and this being identified through imaging studies at the get-go, then perhaps we would start with neoadjuvant chemotherapy, meaning taking chemotherapy first, then following with surgery and perhaps additional therapy. So when we're talking about surgical treatment for endometrial cancer, the common pathway, the surgery involves removing the uterus, also known as typically a total hysterectomy. That is removing uterus and cervix, as well as bilateral salpingo-oophorectomy, also known as a BSO, removing the both tubes and ovaries. This is done by a trained surgeon, typically a gynecologic oncologist. And during the surgery, the gynecologic oncologist will also assess for any spread of the disease into the abdominal cavity. If anything is suspicious or seen, then that will be biopsied and removed if possible. Additionally, we would want to assess the lymph nodes in the pelvic and periaortic areas. And this can be done through several surgical approaches. Most commonly these days, it would be done through a sentinel lymph node biopsy approach, and we will talk more about that in a second. Additionally, most of these surgeries for endometrial cancer are done with a minimally invasive approach, meaning a robotic-assisted or laparoscopic-assisted approach, where small incisions are made on the abdomen rather than a big cut. And this allows for better healing and less complications for the patient. Now, some cases may require open abdominal surgery with a big incision, in particular if the uterus is enlarged or if there's a history of extensive prior abdominal surgery. And again, doing this very thorough surgical assessment is what we define as a surgical staging procedure, which refers to fully assessing the abdominal pelvic cavity for any disease sites or spread of disease. Now, as we mentioned, there are different ways to assess the lymph nodes when we're doing endometrial cancer surgery. The most common is sentinel lymph node biopsy. And this technique has been used for many, many years in breast cancer and melanoma, and actually at this point for many years in endometrial cancer. What it involves is injecting a small amount of dye, most typically indocyanine green dye, to the bottom of the cervix at the beginning of the case before taking out the uterus. And by using this dye, we are looking to see where it travels into the nearby lymph vessels and into the nearby lymph nodes. The lymph nodes that light up with the dye are the lymph nodes that are the best to remove and to test to see if there's any spread of the endometrial cancer cells to the nearby lymph nodes. By doing this technique, it really does improve the success for the patients, meaning there's less complications, there's less surgical time needed. And it has been shown to be very effective for identifying spread to these lymph nodes. This is an improvement over taking out the entirety of the lymph nodes in the pelvic and periaortic area, which used to be done in years past. And there have been many studies at this point showing that this technique is effective, that it is quite effective to detect metastasis with 96% sensitivity, and negative predictive value is very high at 99.7%, meaning that if no metastatic disease is found, it truly is not there. And as of FIGO 2023, which are the recommendations for how to manage endometrial cancer surgically, sentinel lymph node biopsy can be used for all endometrial cancer cases. And what do the pathologists do with these sentinel lymph nodes? They do have a very specific processing technique where they cut the lymph nodes into very, very thin slices, look at them under the microscope, use special stains to see if there are any cancer cells that have spread to the lymph nodes. And they then are able to actually quantify the extent of spread to the lymph nodes using several terminologies, including macrometastases, micrometastases, or isolated tumor cells, as you can see defined here on the slide. How this is relevant is we will see that this is now being incorporated into the most current staging system. So we're going to now review how to stage endometrial cancer. As discussed, there is surgical staging and there is clinical staging. We've just spent a few minutes talking about how to do surgical staging, where a patient actually undergoes surgery and tissue samples are removed, such as the uterus itself, as well as the lymph nodes and other biopsies from the abdominal pelvic area. That is really the preferred way to do staging for endometrial cancer. Now, in some circumstances where surgery is not the appropriate first step, or the patient is unable to undergo surgery, we can do clinical staging. This refers to using imaging information and physical exam findings to identify where the cancer is located. In general, we have always talked about stages of endometrial cancer in the following format. Stage 1, the cancer is only in the uterus. Stage 2, the cancer has spread to the cervix area. Stage 3, the cancer has spread to their nearby fallopian tubes or ovaries, or down into the vagina area. Stage 4, the cancer has spread to areas beyond that. Now, the staging system has been updated for endometrial cancer, and this is actually quite recent. The Federation of National Gynecologic Oncologists organization, FIGO, has now defined the new staging system as of 2023, and it is shown on this slide. What is key to the new staging system is it now incorporates factors such as lymphovascular invasion, grade, histology, which we will talk about more in the upcoming slides, the depth of invasion into the muscular wall of the uterus called the myometrium of the cancer cells, whether there are micro or macro metastases to the lymph nodes by the cancer cells. And in addition, the significance of isolated tumor cells, ITCs, is unclear, though it should be reported and documented if they are identified by the pathologists. And as you can see here, these factors, which primarily come from the surgical pathology report, can then differentiate the cancer stage. If there is extensive LVSI or high-grade cancer type or histology, it does bump up the cancer now up into stage 2 and beyond. So talking about precision medicine in endometrial cancer, here we're going to dive into the newest modality of a treatment for endometrial cancer. What is precision medicine? Coming from the National Institutes of Health, that precision medicine is basically saying that there is not a one-size-fits-all approach for medical conditions and specifically for cancers. And this is also being applied to endometrial cancer as well. I will explain this in the next couple slides. We are really realizing there are many subtypes of endometrial cancer. There really are a variety of subtypes. And we're defining these both based on how they look under the microscope, what we refer to as histology. But furthermore, we're actually looking at the molecular signature of these cancer types, what we call genomic signature. And we're realizing that different type of histologies and different type of genomic signatures are associated with different endometrial cancer outcomes. Furthermore, that there are specific treatments that may be more effective for one type versus another type of endometrial cancer, and that we're referring to as the opportunity to use targeted therapies. We do want to highlight that some types of endometrial cancer are hereditary. Specifically, these are genetic conditions known as Lynch syndrome, which refer to changes or mutations in particular genes as listed in this table, MLH1, MSH2, MSH6, and PMS2. And patients who have this Lynch syndrome condition are at high risk for developing endometrial cancer, as well as colorectal cancer, stomach cancer, pancreatic cancer, ovarian cancer, and kidney cancer. And this particular condition can be passed on from generation to generation. Another genetic condition called Cowden syndrome, which is associated with a change in the PTEN gene, is associated with endometrial cancer, as well as breast, colorectal, thyroid, kidney, and melanoma in patients who carry this gene mutation. And again, this particular condition can be passed from generation to generation as well. So in terms of, again, talking about classification of endometrial cancer, we have what we refer to as an older system. Historically, we thought of the endometrial cancer cases falling into two categories, type 1 and type 2. And these are the features of those that had type 1 being younger, more common, more obese patients, more Caucasian associated, and typically associated with Lynch syndrome and the PTEN genetic conditions we just talked about. More commonly, the histology or the type of cells under the microscope or the endometrioid type. And more commonly, this was thought to have a better prognosis. And then the other category were the type 2s, more classically older, less obese, more African American or Black population, typically a different type of cancer biology with the P53 or other gene mutations, and the more aggressive histologies under the microscope with a poor prognosis. Now what we've moved towards is a histologic and molecular classification. So we're not just simply saying type 1 and type 2. Really, we're actually diving deeper into the histology and molecular signature. And we do have several ways to classify tumors. We still do look at the grade of the cells, which under the microscope refers to the area of solid areas of tumor, as well as the nuclear features of these cells, and reported within a grade 1, 2, and 3 system, 3 being the most aggressive. And furthermore, we're talking about histologies as discussed, which is the kind of what the cell feature looks like under the microscope and classifying them into different categories. These I want to highlight are the most aggressive histologic groupings, including the serous, the clear cell, the mesonephric-like, the gastrointestinal type, the undifferentiated, and the carcinosarcoma. Now, suffice it to say, these are less common overall for histologic subtypes of endometrial cancer, compared to the endometrioid histology, which still remains the most common, comprising over 2/3 to 3/4 of all endometrial cancer cases, and still most commonly being low grade rather than high grade. Now, molecular testing for endometrial cancer is recommended and can provide prognostic information for the patient. What are we talking about with regards to that? So back in 2013, there was a very prominent study called the Endometrial Cancer TCGA study that is shown here in this publication. They were able to do gene sequencing of various modalities of over 200 patients, which then classified endometrial cancers into these 4 categories, as you can see here with the graph on the left. Namely, they're the POL-E category, the MSI hypermutated, which also is generally known as the Lynch patients category. There's also the copy number low, also generally known as the endometrioid or the most common type. And then lastly, the copy number high in the red box, which is a serous-like, also known as the most aggressive type of endometrial cancer cases. And what you can see here is when you categorize them into these different categories, the overall long-term outcomes in terms of survival differ, with the POL-E doing the best and the copy number high in the red line doing the worst. Now, since then, there have been multiple other studies that have essentially imposed a similar molecular classification schema for endometrial cancer cases when taking an entire large group of endometrial cancer patients. The PROMISE publication is applying this classification schema to a European cohort. And when they essentially applied similar classification schema, you can see that there is a difference in survival outcomes, again, with the P53 or copy number high group in red doing the worst, and then those with the POL-E doing the best. Now, since then, the societies for providing guidance on how to manage and treat endometrial cancer, including from the National Comprehensive Cancer Networks. Most recently, 2024 has provided this guidelines for classifying endometrial cancers using the schema just mentioned. When feasible, it is recommended that cancer cases be tested for a POLE hotspot mutation. If that can be done and they are found to be POLE, then that is it. They are classified as POLE cases. If they are not POLE mutated, then further testing should be considered, including doing testing for those mismatch repair proteins or genes as the MMR testing via immunohistochemistry, or directed gene testing. If the patient is found to have mutations there, then they're classified as deficient MMR or MSI high. On the other hand, if they are not found to be deficient MMR or MSI high, then they should also undergo p53 testing, as shown in the right branches there. And if there is a mutation in p53, they are classified as p53 mutant cancers. And if there's no mutation, they are then classified as the NSMP group. And again, what we are seeing is when we apply this type of molecular classification schema, either to large patient populations who undergo generalized care or applied into a clinical trial where there is a large population of patients who are enrolled for a particular chemotherapy radiation treatment. But then after that trial is completed, they then looked at patients who are classified using this 4-grouping approach. It has been shown that outcomes do differ by these molecular 4-grouping approach. And you can see here with the PORTEC-3, which was a randomized clinical trial testing one arm who underwent radiation therapy versus the other arm, patients who underwent radiation with chemo. They did find that those who got the combination chemoradiation in the p53 mutated group overall did better, and that was where there was the biggest benefit to incorporate chemotherapy for these patients in addition to radiation. You can see from the other groupings, the POLE, the MMR deficient, and the NSMP, the benefit of adding chemotherapy to radiation was not as prominent as the curves are all closer together. And again, taking another clinical trial, GOG 258, this was a big randomized controlled trial, again, comparing patients who got radiation chemotherapy versus chemotherapy alone for advanced stage cancer patients. Again, they found that when you sort of subdivide into these molecular subgroups of patients, there was a little bit of a potential difference in outcomes. Patients with p53 wild type had improved progression-free survival with the combination of chemotherapy and radiation versus doing chemotherapy alone. However, this difference was not as seen when you were looking at the p53 mutated group or the MMR deficient endometrial cancer patient groups. Now, of course, this is a secondary analysis of this prior randomized controlled trial, and therefore is only hypothesis generating. So meaning that further studies really need to be done to truly determine if these difference in outcomes, particularly with combination chemotherapy, will be borne out. So we want to dive here into a little bit more detail regarding post-surgical treatment. So as stated, endometrial cancer patients most commonly undergo surgery first, and then there has to be decision-making about whether to do chemotherapy or radiation to follow. So how do we decide who needs treatment after surgery? So broadly speaking, generally speaking, we can have this framework here. Stage 1 patients, those that fall into this high intermediate risk, meaning they have more deeper invasion or factors such as lymphovascular invasion, or they have aggressive subtypes of endometrial cancer, typically will be recommended to take some additional treatment after surgery. The other categories, including stage 2, 3, and 4 patients, generally speaking, will all be recommended to take additional chemo or radiation after surgery. Now we can dive into more granular details. There are guidelines that are provided by different organizations, for example, from the National Comprehensive Cancer Network. And if we're going to look specifically at endometrioid histology cases, here we can dive deeper and to look at the staging information. If it's a stage 1A or grade 1 to 2, then observation is preferred. If it is stage 1A with grade 3, then after hysterectomy and surgery, radiation with vaginal brachytherapy is preferred. And as you go into a higher stage and grade, then generally speaking, there is always some amount of additional radiation or chemotherapy that is recommended, as you can see from this flow diagram. Now, if we're going to focus on serous and clear cell histology endometrial cancer cases, in general, for nearly all patients, additional therapy is recommended after surgery. And this typically involves systemic therapy, which refers to chemotherapy. And that may be combined with some amount of radiation therapy as well, whether it's vaginal brachytherapy applied to the upper aspect of the vagina or additional external beam therapy, which is a radiation that is more diffusely applied to the pelvic area. Now, regarding undifferentiated or dedifferentiated cancers, these again are the most aggressive subtypes of endometrial cancer, and generally speaking, after surgery, chemotherapy, otherwise known as systemic therapy, is recommended. And similarly for carcinosarcoma, also known as one of the most aggressive histologic subtypes of endometrial cancer, typically treated with surgery first, and generally always recommended to have some type of systemic or chemotherapy to follow, with or without additional radiation. So if we're talking about systemic or chemotherapy, what are the drugs used? They are listed here. The most common drugs are carboplatin and paclitaxel. And now, most recently, the inclusion of immunotherapy drugs in addition to the carboplatin paclitaxel. These are pembrolizumab and dostarlimab. We will dive into these details in the upcoming slides. Additionally, if a patient has a HER2 receptor positive type tumor, then trastuzumab is also recommended as a first-line treatment. So with these upfront first-line treatment therapies, we're going to dive into some of the details here. Namely, what is immunotherapy? It is one of the newest forms of cancer-directed treatment. And the principle here is that the type of cancer treatment that we can apply is going to leverage the body's own immune system to prevent, eliminate, or control the cancer. So with regards to immunotherapy, there are different types of immunotherapy, including checkpoint inhibitors, targeted antibodies, cancer vaccines, and adoptive cell transfer therapies. Now, specifically for endometrial cancer, the most notable therapy has been the checkpoint inhibitors. And these include drugs, namely being pembrolizumab and dostarlimab. What these drugs are, they are monoclonal antibodies that bind to the protein PD-1 on the surface of these immune T cells that are in the body. It then keeps the cancer cells from suppressing the immune system, which allows the immune system to basically recognize these cancer cells and to attack the cancer cells to try to get rid of them. So what we have found is that immunotherapy drugs are effective for, in particular, mismatch repair deficient type of endometrial cancers. And this has been borne out through multiple research studies that actually tested different type of immunotherapy drugs in themselves. And they showed impressive response rates as single agent. And you can see here there are several studies listed with overall response rates in the 40 to 50%, which is actually quite high when we're talking about advanced or metastatic endometrial cancer. So with this information, more clinical trials were developed. And these are some of the biggest breakthroughs that we have seen in the last decade or actually half century of endometrial cancer treatment. I want to highlight a couple of these studies. The first one is known as NRG GY018, frequently just called GY018. And this was a very large clinical trial that was published in March of 2023 in New England Journal of Medicine, pembrolizumab plus chemotherapy advanced endometrial cancer. And with these results, they did subsequently lead to the FDA approval of using pembrolizumab with chemotherapy for first-line treatment for advanced endometrial cancer. These are the details of this study. So this particular study was a very large randomized study where they enrolled stage 3 to 4A endometrial cancer patients with measurable disease. They also included patients that had recurrent cancer, but who had not had chemo in the past 12 months. They can have had prior radiation or hormonal therapy. And all histologies except carcinosarcoma were included in this study. And the enrollment was over 3 years' time. Patients either got paclitaxel with carboplatin, which truly is the standard treatment for many, many years, versus the carboplatin with paclitaxel with the new agent pembrolizumab. And in this experimental arm, they then followed with pembrolizumab given every 6 weeks for up to 14 additional cycles. So if you calculate out the math, that's over approximately 2 additional years following the primary triple combination therapy. So what they showed with this particular trial is that pembrolizumab offers survival benefit in terms of progression-free survival for both MMR deficient as well as MMR proficient patients. Now, the biggest benefit was seen in the MMR deficient patient group, where there was a 70% difference in relative risk of progression-free survival, which is incredibly impressive. But in the proficient MMR patients, there also was a statistically significant benefit, median progression-free survival of 13 months versus 8 months. So meaning that the pembrolizumab group had a much improved outcome. Now, looking at overall survival, the data is still a bit immature. There are some results presented at the most recent annual meeting for the Society of Gynecologic Oncology in March 2024. Here we can see, particularly in the MMR deficient group, there is potentially will be a significant benefit, especially in that group for overall survival. The analysis is ongoing and will be reported in the future. So based on this particular study, looking at toxicity, which is overall very well tolerated for patients who did receive the pembrolizumab, you can see here the proportion of patients who had any type of fatigue, neuropathy, anemia, constipation, diarrhea, low platelets, muscle aches, myalgias, neutropenia, low white blood cells, or vomiting. And while the percentages might look high, these are for any grade of toxicity, so it could be mild to moderate to severe. Overall, it was very manageable for the patients. There is also some autoimmune disorders that can occur when using immunotherapy drugs, namely 20% or so of patients had thyroid abnormalities in the pembrolizumab, and about 6% had bowel-associated issues. These can be pretty easily diagnosed and managed safely. So another study that was quite important and prominent, looking at another immunotherapy agent, dostarlimab. This result was also reported at the same time in March of 2023 and published in the New England Journal, as you can see here. And this resulted in FDA approval of using this particular immunotherapy drug, dostarlimab, also in upfront treatment for endometrial cancer. And here are the details. This trial, called the RUBY trial, enrolled stage 3 to 4 endometrial cancer patients that were not amenable to curative therapy. This did include patients with upfront diagnosis, stage 3A to 3C, and it did include patients with carcinosarcoma, and regardless of whether there was measurable disease seen on their CT scan. And so with this particular study, here's the schema. As stated, all histologies were included. Patients either got the standard therapy, which is paclitaxel with carboplatin, or they got paclitaxel carboplatin with dostarlimab. And after going through the 6 cycles of these regimens, if they're in the dostarlimab group, they continued on for 3 years of continued dostarlimab given every 6 weeks. And what did they find? Ultimately, they did find improvement in progression-free survival, but I wanted to highlight the most recent results that were reported was regarding overall survival benefit, showing a 31% reduction of death in the patients that got the dostarlimab drug. And this was seen to benefit both patients who are MMR deficient as well as MMR proficient, that there was a benefit in all of these subpopulations. And interestingly, further analysis where we're applying that molecular classification into those 4 subgroups that we talked about earlier, you can see that the most prominent impact was with the MMR deficient group with the upper right graph, where those that got dostarlimab had impressively improved survival compared to those that just got the placebo. And this is regarding progression-free survival. And in the other subgroups, those that are Pol E, there wasn't so much a difference between the 2 different arms of therapy. And then P53 mutated, there still was an improvement within that subgroup where the dostarlimab group did better. So again, the side effects of dostarlimab with combined chemotherapy overall was still very well tolerated. The discontinuation rate of dostarlimab was about 17% versus 9% in one arm versus the other. And the most common toxicities are reported here. So as we saw in those previous 2 RUBY and GY018 studies, really brought that immunotherapy to the front line for endometrial cancer patients. Now, one other interesting study here, pembrolizumab plus lenvatinib. This is a combination using immunotherapy with an oral pill called lenvatinib. This combination had been tested in patients with recurrent cancer and now was being studied in patients as first-line therapy. And this was a phase 3 randomized controlled trial where you see the comparison with one arm getting paclitaxel and carboplatin, the other arm getting the pembrolizumab with lenvatinib. Ultimately, in this particular study, they found that there was not improvement, or we should say rather, this was a non-inferiority study, that doing the pembrolizumab lenvatinib did not meet statistical criteria for being non-inferior compared to the standard paclitaxel carboplatin. Essentially, this is saying it is a negative study and that this combination has not been borne out to be better per se. And wanted to bring attention to one more trial that's looking at immunotherapy in combination with chemotherapy as a first-line agent. This is a phase 3 randomized trial. It enrolled patients really throughout the world, in Europe and Asia, Australia, New Zealand, however, not in the US. But the outcomes were still promising, and it showed a benefit to those patients receiving atezolizumab, which is another immunotherapy drug combined with paclitaxel and carboplatin. And here they did show that was a definite improvement in progression-free survival, as well as a signal for improvement in overall survival. So again, more evidence that immunotherapy with combined chemotherapy upfront is beneficial. So to summarize, in the US, the GY018 and RUBY trials really showed that immunotherapy is beneficial in upfront treatment of endometrial cancer, especially with those with stage 3 advanced cancers, and especially beneficial in those population with mismatch repair deficient cases. But it also can be beneficial for those with proficient cases as well, and it is overall very well tolerated. And further, there are additional clinical trials studying these immunotherapy drugs combined with radiation or other drugs that are ongoing. Now we want to switch gears a little bit and talk about chemotherapy and systemic therapy options for endometrial cancer cases where there has been recurrence or progression, meaning that unfortunately after getting the first-line treatment, the cancer has either continued to grow or has come back. And in this setting, there are different drugs that are commonly used, and they're listed here, meaning paclitaxel, carboplatin, pembrolizumab, dostarlimab, other drugs such as trastuzumab, lenvatinib, bevacizumab, and additional agents listed on the table on the right. Here, we want to highlight how we're moving towards a more refined precision medicine approach for when cancer recurs. And really, we are looking at using these novel targeted therapies and looking at the molecular signature of the cancer. So for those who are particularly p53 wild type, meaning not mutated, using agents such as bevacizumab and selinexor could be most beneficial. With those regarding HER2 type tumors, using trastuzumab or trastuzumab deruxtecan. And with those regarding the cases that are p53 mutated, using PARP inhibitors could be particularly beneficial. And those cancer types that are copy number low or potentially have hormonal receptor positive, using aromatase inhibitors with CDK inhibitors may be particularly beneficial. And we want to highlight some of these most recent studies. So as stated, in recurrence of endometrial cancer, one of the most notable studies was Keynote 775, which is a combination of pembrolizumab, lenvatinib. And this particular study, which was a phase 3 randomized controlled trial, comparing the two, showed that there was a benefit in progression-free survival as well as overall survival. And with this, immunotherapy was approved by the FDA in 2021 based on these trial-associated results. As you can see here, granting approval to pembrolizumab and lenvatinib for advanced endometrial cancer. And just wanted to highlight, based on this study as well as other specific studies, FDA did approve pembrolizumab alone as a single agent for MMR deficient or MSI high endometrial cancer cases in 2022. This is namely in the recurrent setting. Other newer studies targeting other agents, including HER2. This was a phase 2 study specifically enrolling stage 3 or 4 recurrent endometrial cancer patients with serous histology. They received paclitaxel carboplatin with or without trastuzumab. And those that received this trastuzumab agent especially were found to have a progression-free survival benefit of 12.9 versus 8 months. And furthermore, the biggest benefit was found in those who had stage 3 or 4 cancer undergoing frontline treatment. What is really exciting for those who have HER2 type tumors is this newest study called the Destiny trial. And this was a trial that enrolled patients with multiple different types of cancers, including endometrial cancer, as well as cervical, ovarian, biliary, pancreatic, bladder, and others, as you can see from the figure on the right. Now, within the endometrial cancer cohort, where 70 patients were enrolled, and the patients had HER2 or HER2 immunohistochemical staining that was 2+ or 3+ positive, either receiving 1 to even 3 or more lines of prior therapy, there were actually quite impressive results, as we'll see here. In this trial, those who had immunohistochemical staining, HER3+, for HER2 that were 3+ on the staining, the overall response rate was 84%. And those that were 2+ staining, the overall response rate was 47%. These results are really, truly quite impressive for patients in the recurrent setting. Duration response was 3 to 33 months, and median overall survival was 26 months. Toxicities are, as reported here, generally manageable. Another modality of therapy addressing DNA damage repair p53 mutated populations, where we're using PARP inhibitors and adding these to first-line immunotherapy. So this was a study that is named Ruby Part 2. So earlier we had talked about Ruby Part 1. In this Ruby Part 2, they have used carboplatin paclitaxel with the addition of dostarlimab and a PARP inhibitor called niraparib, again, including stage 3 to 4 patients or the first recurrence, and including carcinosarcoma patients, nearly 300 patients. And what they found with this addition of the niraparib to the dostarlimab arm, there was an even improvement in progression-free survival versus just the standard therapy of carboplatin paclitaxel. And this is being shown in both the proficient as well as deficient MMR group. Again, very promising results. Overall survival data still pending. Another study that incorporated PARP inhibitor drug into treatment of endometrial cancer. This is called the DUO-E study, placebo-controlled double-blind study, randomized control trial, where they used durvalumab plus carboplatin paclitaxel with or without olaparib, the PARP inhibitor pill. Again, newly diagnosed stage 3-4 recurrent endometrial cancer, first-line therapy, and they did exclude sarcoma. And what they showed here was that there was a benefit when you use that combination of durvalumab, which is an immunotherapy agent, plus a PARP inhibitor, added to the paclitaxel carboplatin, and that there was a benefit for both progression-free and overall survival, as you can see when you do this quadruple agent arm. And using PARP inhibitors as maintenance, this is another study that was recently reported on with a different PARP inhibitor pill called rucaparib, phase 2 study, where they randomized patients to get the actual pill versus placebo in a metastatic or recurrent setting. And again, they found that there was a progression-free survival benefit with taking this pill, as you can see here from the figure below. So together, potentially a lot of benefit for incorporating PARP inhibitors. And here, another targeted therapy using a different mechanism called nuclear export therapy. This is a particular drug called selinexor, and it potentially may have the greatest benefit for the p53 wild type cases. This is a phase 3 randomized double-blind placebo-controlled trial that was recently reported upon, and it is used in a maintenance therapy setting for advanced or recurrent cancers. Here, again, you can see that there was a progression-free survival for, the progression-free survival was not per se statistically significant overall. However, when they did a pre-planned exploratory subgroup analysis of those specifically with p53 wild-type tumors, it looked like there was a benefit for this particular group of patients of a median progression-free survival of 13 months versus 3 months, as you can see here. And speaking about hormonal therapy, there are particular subgroups of endometrial cancer patients who have, for example, estrogen receptor positive tumor types. And there are now several studies that show hormonal therapy agents may be particularly benefit in this group. Here, one of the earlier studies, phase 2, looking at letrozole and everolimus, persistent or recurrent endometrial cancer cases, it was randomized, comparing this combination versus tamoxifen medroxyprogesterone. 74 patients enrolled, and they did show a clinical benefit in the letrozole everolimus arm. Other hormonal studies have since been conducted and are being conducted. 2 very recent trials are reported here. Paleo trial, looking at a combination of pills, letrozole and palbociclib, which is a CDK inhibitor pill. They studied stage 4 or relapsed estrogen receptor positive endometrioid histology type endometrial cancers. No limit on prior lines of prior therapies. And they did show that there was efficacy for this particular combination. Grade 3 toxicities were more common with the combination. However, again, still reasonably tolerated and a good option potentially for patients. And a different trial also looking at use of CDK4/6 inhibitors. This was a phase 2 single-arm study combining letrozole, again, an aromatase inhibitor pill, with abemaciclib, a CDK inhibitor pill. Again, specifically in patients with estrogen receptor positive recurrent endometrial cancer. No limit on prior lines of prior chemotherapy. And they did find an overall response rate of 30%. With a median progression-free survival of 9%, still a very reasonable option for treatment. So where are we headed? There are many ongoing studies at this point in time, and these are just to mention a few. Immunotherapy for MMR deficient. Can we use just an immunotherapy drug alone without the additional other chemotherapy agents? And would this do just as well? So these are a couple ongoing trials that are mentioned, Keynote C93 and the Dominica trial. In other situations, what do we do after patients have recurred or progressed when they've gotten immunotherapy in combination with chemotherapy? Do we use something like pembrolizumab, lenvatinib, or other combinations with other targeted agents, CTLA-4 inhibitors, etc.? We will wait for all these ongoing trials and their results. And really, should we use immunotherapy in early stage endometrial cancers like stage 1 and 2s? There are ongoing trials to investigate this question, such as the GY 020 trial. And further, can we incorporate molecular classification into early stage adjuvant therapy management? And this is depicted here with the ongoing Rainbow trial. So to round out the talk, we did talk about radiation therapy earlier, and suffice it to say, there are various modalities of radiation therapy that can be very beneficial to endometrial cancer patients. And these include vaginal brachytherapy, use of external beam radiation therapy, otherwise most commonly intensity modulated radiation therapy is the specific type that's used today. They use multiple fields to shape the high-dose radiation, which better spares the bowel, bone marrow, bladder, and rectum areas. And there are even newer modalities of radiation therapy, basically different types of energy that is delivered to the targeted areas, including stereotactic body radiation therapy, which combines the conformality of IMRT with robust immobilization methods to ablate lesions with millimeter accuracy inside the body, and can be applied to areas that have been previously radiated. There are multiple clinical trials underway within this for gynecologic cancer, including endometrial cancer, and additionally proton therapy type of radiation therapy that can better target tumor tissue, again, sparing other nearby tissues. And there are several studies in clinical trials right now studying this as well. So all in all, the developments for endometrial cancer in terms of novel therapies is really groundbreaking, especially in the past few years. And truly, what has brought about these novel discoveries is participation in clinical trials. So a clinical trial is a research study involving human participants assigned to an intervention in which the study is designed to evaluate the effect of the intervention on the participant. And we have just covered many, many trials in the last hour that have really brought out new discoveries, new treatment opportunities for patients with endometrial cancer that is so much more refined, so much more targeted than we've had in decades past. Where do we find clinical trials? Certainly you can look at several available web pages, including here listed the OCRA webpage, as well as clinicaltrials.gov, where clinicaltrials.gov basically has all registered clinical trials for all disease sites, including endometrial cancer, and is a really great resource for looking for clinical trials. And together, if we join together in this partnership where we are participating in clinical trials, looking for more funding to support all this research, improving our access to all these novel therapies, both in clinical trials as well as for standard of care, and truly increasing our education and awareness regarding endometrial cancer, we will together move the field forward. And so in conclusion, endometrial cancer is the most common gynecologic cancer with a rising incidence and mortality that is particularly affecting racial subpopulations of Black, Hispanic, and Asian patients. Fortunately, we do have more therapies, including immunotherapy, that have shown greater benefit for our patients, and that the molecular classification approach is truly driving our current research and discoveries for new therapies. Hopefully, we can improve our ability to study endometrial cancer and identify new therapies with further funding, and we can together mobilize a community of patients and providers to educate, advocate, and bring new therapies for everyone. Thank you so much for your attention.